So, acquired syphilis caused by spirochete bacterium Treponema pallidum. In adults, the disease is usually sexually acquired when organisms enter through skin or mucous membrane abrasion. Transmission by kissing, blood transfusion, or percutaneous injury is rare. Transplacental infection of the fetus can also occur when the mother has become infected during or shortly before pregnancy, known as congenital syphilis. Systemic features. The natural history of untreated syphilis is variable. Primary syphilis is characterized by a painless ulcer known as chancre, commonly in the genitalia or anus. Secondary syphilis consists of a maculopapular rash and other systemic features as shown in this picture. The other systemic features are malaise, sore throat, headache, weight loss, low-grade fever, pruritus, muscle aches. Then there is latent syphilis, in which zero reactivity without visible signs or symptoms, in which there is early latent disease within 2 years of infection and late latent disease after 2 years of infection. Then there is tertiary syphilis. It occurs in about 40% of untreated cases. So this tertiary and is characterized by cardiovascular manifestation, aortitis, neurosyphilis, comatose infiltration of bone and viscera. Ocular features. Anterior uveitis occurs in about 4% of patients. About 4% of patients with secondary syphilis. Secondary syphilis, in which there is maculopapular rash and other systemic features, which we discussed. Granulomatous, it may be granulomatous or non-granulomatous, bilateral in 50%. Roseoli are dilated iris capillaries, as shown here. That may develop into yellowish nodules. The IOP may be elevated. Chorioretinitis, it can be localized but is often multifocal bilateral associated with vitritis. Exudative retinal detachment can ensue. Acute syphilitic posterior placoid chorioretinopathy. There are large pale yellow subretinal lesion in the posterior bole, thought to be due to retinal pigment epithelium infection, and occurs more commonly in the immunocompromised. Retinitis, ground gloss appearance associated with scolitis, may be occlusive, involve both arteries and veins. This heel leaving diffuse chorioretinal scars. Optic neuritis, neuroretinitis. Other features: conjunctivitis, episcleritis, scleritis, intermediate uveitis, glaucoma, cataract. Miscellaneous neuroophthalmic features related to CNS involvement include agate Robertson pupils. Investigation. Serology is the mainstay. Systemic assessment. And in the serology, treponemal antibody tests such as ELISA are highly sensitive and specific, but takes around 3 months to become positive. Non-specific titratable cardiolipine antibody tests such as the rapid plasma reagent or venereal disease research laboratory test, positive in the early infection, and are used to help monitor disease activity. They become negative over time, typically in untreated disease. False positive results can occur. Both categories of tests should be performed when screening for ocular syphilis. Clinical features suggesting of diagnosis of syphilis should prompt urgent referral to a physician specializing in infection or sexually transmitted diseases. Systemic assessment by appropriate specialists include LP to rule out neurosyphilis, HIV status. Aqueous or vitreous sampling per PCR is sometimes done when HIV positivity makes serology less reliable. Treatment by specialist usually consists of parenteral penicillin. In case of penicillin allergy, the alternatives may be required that are less effective. Topical systemic steroids are given in conjunction with antibiotics. Jarisch-Herxheimer reaction is a systemic response to treponemal antigen release on commencement of therapy and may include progression of ocular signs. And there is Lyme disease known as borreliosis. Like syphilis is caused by a spirochete. The responsible organism is Borrelia burgdorferi. Transmitted through tick bite, with deer being an important vector. The deer is an important vector. So, an adult tick can be distinguished from a head louse by the tick is having 8 legs. It is arachnid and louse 6, though larva ticks have only 6. The disease is endemic in the regions of North America, Europe, Asia. Difficult to diagnose. Several days after a bite, an annular skin lesion, Rhythema chronica migraine. This is Rhythema chronica migraine. So, it forms at the site of lesion, Rhythema chronica migraine, in 60 to 80%, accompanied by symptoms like this is known as stage 1. Neurological, like cranial nerve palsies and meningitis occurs. Cardiac, 4 to 8%, arrhythmias. Other manifestation may follow within a week. So this is stage 2. Stage 3 is the stage of complication like chronic arthritis, polyneuropathy, encephalopathy. Some patients develop chronic symptoms that may not respond to antibiotics. The ocular procedures occur in stage 2 and 3. Uveitis is uncommon, but can be interior granulomatous and non-granulomatous. Intermediate is the most common. Posterior multifocal choroiditis, vasculitis, neuroretinitis. Other manifestation in stage 1: transient conjunctivitis, bilateral stromal keratitis, episcleritis is shown here, scleritis, orbital myositis, optic neuritis, papilledema, ocular motor facial nerve palsy. 25% of facial nerve palsy in endemic areas. Investigation serology should be performed a month after infection. False positive can occur. PCR per CSF, synovial fluid is performed. Treatment is of early acute disease is effective. Involve oral doxycycline but not in children or pregnancy. Amoxicillin, erythromycin. Untreated many patients with early or asymptomatic disease will experience no further problem. Patients with established disease including ocular may require extended intravenous penicillin or ceftriaxone. Keratitis uveitis may need steroid treatment. Systemic steroids should not be given without concomitant antibiotics. And personal protection like clothing, insect repellent should be used. Lyme disease vaccine is available but does not offer complete prolonged protection. Brucellosis is a gram-negative bacteria, Brucella melitensis and Brucella abortus, transmitted from animals to men through milk products or uncooked meat. A variety of constitutional and ocular features are reported. Ocular features include chronic anterior and posterior uveitis, papilledema, retinal hemorrhage. Serology and blood culture are done. Treatment is 2 antibiotics, streptomycin, doxycycline, and steroid if required. Endogenous bacterial endophthalmitis. So, the Roth spots develop in about 1% of cases of bacteremia, but no frank ocular infection occur in the great majority of cases. A wide range of organisms can be responsible. Gram-positive predominantly in North America and Europe, gram-negative in Eastern Asia. Risk factors include debilitating disease of many types, as well as other factors such as intravenous drug abuse. Spread can occur from any potential focus such as unwilling catheter or septic joint. Patients are usually systemically unwell. Mortality is relatively high, 5 to 10%. Prognosis is poor than post-operative endophthalmitis. Diagnosis is delayed. The main distinction is from endogenous fungal endophthalmitis. Symptoms are blur vision, pain, redness. Signs are similar to post-operative endophthalmitis. Retinal infiltrates may be early features, reflecting the root of infection. Search for septic focus, blood or urine culture, septic arthritis, endocarditis, lumbar puncture. Should be in collaboration with appropriate physician. Aqueous filter sample should be taken. Treatment of systemic infection with intravenous antibiotic. Endophthalmitis treated with intravitreal and oral fluoroquinolone. Systemic steroid role is undefined. PPV may improve prognosis in some patients. Cat-scratch disease, Bartonellosis, caused by Bartonella hensleyi, gram-negative rod. Infection is mediated by scratch or bite of healthy cat. Feline contact is not always described. Red pupil at the site of inoculation are followed by fever and regional lymphadenopathy. Those general symptoms are frequently absent. Severe systemic disease occasionally occurs. Visual prognosis is usually reasonable. Ocular features in 5 to 10%. Neuroretinitis is the most common manifestation. There is a disc edema, macular exudates in the star formation. IU, focal retinochoroiditis, vasculitis, rarely optic nerve head, angiomatous lesion, conjunctivitis with conjunctival granuloma, preauricular lymphadenopathy known as Paranoid oculoglandular syndrome may occasionally be seen. Investigations include serology. Treatment is doxycycline 100 mg twice daily 4 to 6 weeks in immunocompetent. Oral erythromycin in children. Other like cotrimoxazole, trimoxazole, azithromycin, rifampicin, ceprofloxacin are effective. Steroid in some cases. For mild syndrome, treatment is not usually given. Leprosy, Hansen disease, chronic granulomatous infection by Mycobacterium leprae. Mode of spread remains uncertain, though nasal secretion have been implicated. There is chronic immune response, leads to peripheral neuropathy. This is primary pathogenic mechanism. Genetic factors are important. 5% of general population is vulnerable to leprosy. Systemic features, there is tuberculite falcibacillary. In tuberculite, one or more hypopigmented macules in aesthetic skin patches. In the borderline, this is known as multibacillary. The most common form, similar to tuberculite but more numerous and extensive lesion. This is similar to tuberculite. So the hypopigmented macules are more numerous and the skin patches are more numerous. Lepromatous is multibacillary. There are cutaneous thickening, leonine facial appearance, peripheral plaques, nodules, respiratory tract involvement, nerve lesions, facilitating trauma, shortening and loss of digits. Ocular features are due to direct bacterial invasion, keratitis, beaded corneal nerves, punctate, subepithelial lesion, painous vascularization, anterior uveitis, chronic low grade, known as plasmide, due to prominent fibrine, miosis, iris atrophy, impaired dilator pupillary innervation, iris pearls are pathognomonic, under 0.5 mm in diameter. Other features are episcleritis, scleritis, retinal pearls, uveal effusion, cataract, glaucoma, decreased corneal sensation, facial nerve palsy, eyelid deformities, phthisis bulbi. Investigation, skin and occasionally ocular specimens show acid-fast bacilli, lepromine test, distinguish between tuberculite and lepromatous leprosy. Treatment is antibiotics such as dapsone, rifampicin, clofazimine, BCG vaccination, steroids for uveitis.